Om Shri Manjunathaya Namaha. Good morning everyone and welcome to today's session on the topic of neurological disorder. Without further delay, I would like to call upon Dr. Muralidhar Sharma sir, SDMCA Udupi, to take over the session. Welcome to you, sir.
Okay, now in the last session we had discussed about the nerve compression disorders like carpal tunnel. The next part would be about the neuralgias. There is a specific word called neuralgia. That means the pain produced due to an impairment of the functions of the nerves. And it's a very vague word. It could be produced due to, or it could be produced anywhere. When the nerve is compressed or nerve is irritated, it can produce the neuralgia. But among the varieties of the neuralgia, one common clinical condition is a trigeminal neuralgia. Trigeminal neuralgia is it's not a single disease entity. Could be produced due to multiple factors, and there are many conditions which mimic the trigeminal neuralgia. Like a simple toothache also can produce confusion with the trigeminal neuralgia, and that's why there is a need of defining that trigeminal neuralgia. And the international classification of the headache disorders, trigeminal neuralgia is defined as a typical paroxysmal attacks of pain lasting from a fraction of a second to 2 minutes for a short duration and affecting any one division of the trigeminal neuralgia, and it has at least the following characters like it's intense, sharp and superficial or stabbing, and is precipitated by trigger areas or by certain trigger factors. Trigger factors could be simple cold, very commonly it's the cold, it could be touch, it could be biting some hard substances. At times it could be even due to the external stimuli like light or maybe sudden light or sudden sound also can precipitate this triggering, or it can be triggered as such. So a pain which is triggered due to certain external stimulus and lasts for a short duration and it's very severe, and it's considered as the trigeminal neuralgia. And it's said the attacks are very much similar in all the patients, and there are no clinically evident neurological deficit. If there is a evident neurological deficit, then it has to be ruled out, like there could be a damage to the nerves. Now this has to be differentiated. Clinical point of view, this has to be differentiated from other conditions. Like where there is a neurological deficit, it cannot be diagnosed as trigeminal neuralgia. It could be due to the other causes, like there could be a nerve compression or nerve destruction. A typical trigeminal neuralgia classified doesn't have any organic pathology of the nerves, and of course it's only a functional disorder, and there should not be any other disorder like a toothache which can produce that. So in any case of trigeminal neuralgia, the major issue is about the clinical examination. Investigations are secondary. Investigations are done only to rule out other coexisting pathologies. Typical presentation of a trigeminal neuralgia would be, it could be in any of the major roots of the trigeminal nerve. The trigeminal nerve, the major roots are, one is the superior branch, which reaches up to the orbit, around the orbital area, pre-orbital area, and then the middle branch, the masseter. Majority of the patients would have the pain in this middle branch asset. Lower branch would be towards the mandibular area, and so it could be very often the patients who present in our clinical condition, majority of the patients are in the middle branch, the inferior alveolar and the lingual nerve, which is affected quite frequently, and hence the pain would be very much in the masseter area asset. So that's the typical feature. Of course, investigations are only to rule out other pathologies. Occasionally, a vascular pathology, as you see a dilated blood vessel over the area, may produce a compression of the trigeminal nerve. But in this vascular pathology, there will be some neurological deficit too. So to rule out neurological deficits or to rule out other mechanical pathologies where there could be a damage to the nerve, compression of the nerve, or at times it could be a parotid tumor which may produce a compression of the nerves, can also present with the features of the trigeminal neuralgia. but the pain which is produced due to the compression would not present as a episodes of pain with the triggering phenomena. Whereas if it is produced due to other lesions, the pain could be constant. So that constant pain and trigger pain that has to be ruled out. So now that kind of a condition where there will be episodes of pain is very characteristically described as the ardita. Ardita, where the patient would have Vakri Bhavati Vaktardan Vivacha Apavartre. Due to the pain, the patient would have make the face constricted, that muscles will be constricted. And it also can present with the neurological deficit. The only difference between the contemporary neurology and Ayurvedic concept of Ardita is the Ayurvedic concept of Ardita involves both the patients who have the neurological deficits as well as the episodes of pain. So one variety of the Ardita is where there would be acute pain which could be related to Shira, Nasa, Osta, Chibukal, Lata, Ikshana, Sandiga. It could be in the same branches of the trigeminal nerve, and it produces acute pain where the patient may make the muscles shrink or constricted as such. Another group of the patient may have the neurological deficit where Vak Sandaha, Netradinam Chibaikitam, these also could occur in another group of the condition. So that's the issue. In the contemporary neurological approach, neuralgia and the nerve compressions are considered as two different conditions. Ardita, according to Ayurveda, considers both these as a single name, or the disease is named as single name of Ardita. But there would be a difference in the approach to the treatment. Now, in case of those typical neuralgia pain conditions, which I consider as Kevala Vatajanya Vyadhi, I would be prescribing Smritisagarasa Ekamvira Sarasvarista Anutailanasya. In very severe cases, Tailadhara and Matra Basti also could be prescribed. Whereas those patients with the neurological deficits, they could be considered as the facial palsy conditions or Bell's palsy or facial palsy conditions. Facial palsy is another of a misleading condition in the clinical practice related to the neurology. A typical the facial palsy, to understand the phenomenon of the facial palsy, you have to have a fair idea of the pathway of the nerves, facial nerve. The one important is the facial nucleus, which is intracranial, is just below the pons, in the subpons area. The facial nucleus is there, and then it passes through the geniculate ganglia and passes through the facial canal. So one important critical area is the facial canal, a bony canal, through which the nerve passes through. Now, majority of the patients who have a Bell's palsy, a clinical condition called as Bell's palsy, would have an inflammatory pathology in the facial canal, and due to the inflammation, that root of the facial nerve would be either partially compressed, and hence it can produce a temporary loss of functions or impairment of the functions transiently. This inflammatory pathology is reversible, whereas there could be any other pathology which could be in the geniculate ganglion level or at the hair level, maybe in the proximal level, which we consider as upper motor neuron lesion. And in that condition, the lesion could be due to some other pathology like either a tumor or a vascular pathology or so on, compression over the area, or it could be even demyelination, where the pathology may not be reversible. So from the clinical point of view, it's important to make out whether the lesion is due to upper motor or the lower motor. The lower motor pathologies, majority of them are the inflammatory or what we call as Bell's palsy. And in a typical Bell's peripheral palsy, Bell's palsy, one of the important clinical sign is the impairment or these forehead lines or the muscles of the forehead, they too would be affected, and hence there will be no forehead lines on the affected side if it is a peripheral palsy. Whereas in a central palsy, this would not be affected. So when you ask the patient to raise the eyebrow, if the patient shows that forehead lines, the horizontal lines over the forehead are seen, then it could be an intracranial pathology which needs a thorough investigation. Whereas if it is affected, then it's a lower motor neuron pathology, and it could be reversible of a variety of the facial palsy. The other internal conditions which may produce are like hemangioma, a tumor mass at the near the facial canal or just below genicular nucleus, can produce a compression, whereas a simple edema, which can be, of course, a imaging study like a CT or MRI may not confirm the edema. Only occasionally you may get an impression of the edema in a MRI image, whereas the other tumors, like tumors or other lesions, which produce a compression of the nerves, they can be made out with the imaging studies. So imaging investigations are necessary only when you suspect a intracranial pathology or the upper supranuclear lesion. Whereas intranuclear or external lesions, you don't need that. So that's about the facial palsy, which is also another form of the autism. And in this condition too, my treatment would be a similar condition, a similar treatment as that of the facial neuralgia, the trigeminal neuralgia. The only difference would be it's important to rule out the issues related to the compression. If there is a compression effect and upper motor condition, the outcome would be poor, patient may not recover. Whereas in the lower motor variety, with the same treatments, Misagara and Anutelanasya, the patients would recover very well, and the duration of the treatment also is relatively shorter. We don't need to have steroids. Whereas the other standard protocol of the treatment, in case of these patients who have edema, the facial canal edema and inflammatory edema, the choice of the treatment is the glucocorticoids given in for a short duration. Anyway, that's one of the conditions. Now, another of the condition, which is again a vague term and which often is presented clinically and quite commonly coming to Ayurvedic hospitals, would be the migraine. Migraine again is a very broader term. It doesn't suggest a single entity of pathology. The typical presentation is of a headache where the patient feels like it's either tropic or pulsatile headache, and which is often related to movement or the physical activity or at times certain triggering factors. Triggering factors also are common in case of the migraine. So it's quite important to differentiate between migraine and the trigeminal neuralgia. Now, in typical migraine conditions, the location of the pain would be anywhere, but majority of the patients would be in the temporal or ocular area near the eyes or in the forehead that the patient may have the pain. And often it may be felt around the head and the neck. And the characteristically, pain starts gradually, increases for a short duration, and then it becomes diffused. So initially, when you take the history, it's very characteristic, like the pain starts at certain specific point, and then it gets distributed to, and it can get distributed through all of the scalp area occasionally. And it lasts for quite a long time, like 4 hours to 70 hours. That's the difference between a trigeminal neuralgia and the migraine. Neuralgia lasts for a few minutes, whereas migraine lasts for hours as such. And quite common, there will be nausea and vomiting, which is also one of the important issues. And one of the important clinical signs, which is often missed in the textbooks, would be tenderness in the cervical area. When you make the patient flex or bend forwards, and you press up on the cervical segments, like either C6 or C5 segment, there can be tenderness elicited. And in a patient of migraine, majority of the patients would have that kind of a sign seen. And another is patient may also have a sensitivity to light and sound. Exposure to bright light or sudden sound often can produce this. And other common clinical signs are there could be even a muscle tenderness in the cranial area. That's what I said. Like that's a very common scene. And some of the patients, particularly during the attack, they may have a unequal pupillary size Horner syndrome, where the patient's pupillary size may be unequal, and this should be seen only during the attack. You do not expect these signs in between the attacks when the patient doesn't have the pain. You may not expect these signs of a constriction of the pupils on one side, or even there could be drooping of the eyelids, a partial ptosis on the same side as that of the headache. It could be during the attack only. Otherwise, you may not see those signs. Patients also may have irritation in the conjunctiva, reddish discoloration also could be one of the clinical signs, but not necessarily in every patient. A patient of migraine tends to have the cardiac arrhythmias. Either it could be tachycardia or bradycardia. Again, it also is often accompanied with the attack. During the attack, the cardiac pulse rate could be altered in patients of this migraine, and all these clinical signs are important to differentiate it from other causes of the headache. There could be even changes in the blood pressure in patients of migraine again during the attack. Often it could be like a wide fluctuation could occur. Either severe hypertension or severe hypotension during the attack is also a common phenomenon. And occasionally patients may have neurological deficits temporarily. Temporarily at that phase where at that area where the patient would have headache, either it could be neurological deficit in terms of the impaired motor activity, twitching of the muscles in the area also may be seen, and often is said as a complicated migraine. Patients who have the neurological deficit, they are classified as a complicated migraine, and usually the outcome would be poor. Or it could be like patient may have a lesser reactivity to the light, and when I say lesser reactivity to light, just expose the eyes to the light, the pupils may not constrict properly, and that's called as any type of the pupil, where it may be just retarded. Many of the patients also may have a symptom of aura that they may know, like exactly when the patient would have that episode of peel. Prior to that episode of peel, the patients may have some symptoms, like often it could be like a bright field in the eyes. Patients may some visual or maybe sensory. Some patients may say that they hear some words or some sounds in the ear. Some say that they see some bright light or so on, or some may complain of certain motor activity, some tremors or twitching of the hands, which may produce a confusion with the seizure disorders. But history is quite important, and often the visual symptoms may be at times patients may have the visual symptoms, but attack may not occur. But at times the visual symptoms may produce the attack, whereas the other aura symptoms, they are very consistent, and this is one of the other variations in case of the migraine which you see. The triggering factors in the migraine also are quite typical. Hormonal changes like menstruation or pregnancy or ovulation, these are very well-known triggering factors as well. And it's also true that incidence of migraine in females is much more than the males. It's almost about more than 3 times. The ratio of male to female is around 1:3. That's for one male patient, there will be 3 female patients. That's the average ratio of incidence. Stress is another issue. Excessive or insufficient sleep is also a triggering factor. And quite important, another is medicines also. Among the medicines, oral contraceptives and vasodilators. And the crucial issue is many of the patients of migraine, they are treated with vasodilators. Vasodilators also are considered as one of the choice of the treatment in case of the migraine. And vasodilators themselves can be a triggering factor. This happens in a large number of patients. Initially, they are given these drugs like nitrites are often given in low doses, and initially the patients may feel better, but after a month or so, or maybe a short duration, these drugs themselves will trigger, and at that time the patients may come to a Ayurvedic doctor. Now, at that situation, it's quite important that we should stop that medicine. Otherwise, this would continue. Patients may not really feel that relationship between the consumption of the drug and the triggering factor. So, clinically, these are quite important issues. Oral contraceptives also are known to produce a migraine triggering as such, and hence a detailed history is important. And of course, the other factors like smoking, bright light, or strong odors, these also are well known. Weather changes, another is weather changes, movement, and extreme like cold substances like ice cream. These also can be the triggering factors as such. So that's about the known triggering factors about migraine. So in the history, it's quite important. Before you confirm whether it's a migraine or not, it's quite important that the headache has to be classified. It's often said that headache is a headache in the clinical practice. So causes of the headache could be many, including the classes could be the cause of the headache, and hence it's quite important to rule out the other causes of the headache. And the IHS has classified the secondary headaches as either trauma-induced, vascular disorders, non-vascular, substance use induced, non-cephalic, metabolic, cranium or neck eye disorders, and the cranial neuralgias. So cranial neuralgias like trigeminal neuralgia also are classified under the headache issues. Psychiatric disorders, this is how it's classified, and you need to rule out these. I will not go into the detail of how to rule out these issues, but it's important to rule out before you conclude whether it's a migraine or not. Now, migraine, from Ayurvedic point of view, from my clinical approach point of view, I would consider this as a Arthavabedaka, and the typical triggering factors are exactly the same as we have discussed earlier: Rukshasana, Adhyasana, Pragvata, or Maithuna, Vega Sandharana, Ayasa, Vyayama, etc. that can produce a typical pain which could be very severe, and it could be Lata Arthe Ativedana, usually located one area, and the pain is so severe like as if it is being pricked with produced by a sharp instrument, Shastra Aranilibha, or it could be the burning sensation. Now, from the clinical approach point of view, I categorize that Ardhava into two categories. One is the Pittavarta, where the patient would have Aranilibha, burning pain, or the other is the Kaphavarta or the Sakapha condition, where the patient would have a consistent, comparatively low incidence pain. Approach to the treatment would be in those patients who have that Pittaja Lakshanas, burning sensation, right? My prescription would be Smithsagarasa, Chandraprabha, or Kamaduta, and Sarasvarisa. Considering this, the Avarana has such one of the dosha Avarana Lakshanas, and Anutela Nasya is given. Whereas if it is a Kafaja Vyati, or often in that condition, the patient also may have discharges from the nose. Along with the headache, the patient may have the discharges from the nose too, or nasal mucosa may be congested. That condition, my prescription would be Mrityunjaya Sudhshekara Pacharikada, and of course, Anutelanasi is a common factor in both the conditions. That's about the migraine and its management from the clinical point of view. Now, another typical clinical condition which is presented as the pain related to the nerves, the neuralgias, among the neuralgia. Of course, there are large variety of neuralgia. To discuss all the variety of neuralgia is not possible. So I would pick up only those which are clinically important, clinically common conditions. Among those common clinical conditions, which again, clinically common conditions which end up in Ayurvedic hospital. Post-herpetic neuralgia is one of the conditions. The herpes, as such, it's well known, like the viral induced pathology related to endings of the nervous system, and most of those patients who are treated with the antiviral drugs for the herpes, they tend to develop these post-herpetic neuralgia quite frequently. When I say this is not a fact which is mentioned in the textbooks. The textbooks say the other ways. In the textbooks, what they say is that those patients treated with the antiviral drugs, they would have a better outcome, and those patients who are not treated with antiviral drugs, they would have a poorer outcome or longer duration. But what I have seen in my clinical practice is just the opposite. Those patients who are treated with the antiviral drugs, the total duration of that eruptive phase of the herpes may be shorter, but they tend to develop that post-herpetic neuralgia and it lasts for a longer duration. And most of those patients end up in Ayurvedic hospital. Whereas those patients who are treated with Ayurvedic medicines in the beginning of the herpes, and the phase of eruption may be looking severe, you may have more eruptions, more bleeds, but it heals well, and the post-herpetic neuralgia phase is shorter. Basically in the herpes conditions, the initial phase of eruptions it may look ferocious to the patient. So patients may be more concerned during that phase, but the later phase, patient would be much better, and the recovery would be usually shorter. Usually within 2 weeks, the patient would recover completely when we start with our treatment. But if the patient develops that, or even after that healing of the lesion, when the patient continues to have the pain in the area, and that pain is quite troublesome to the patient, it's quite severe, often even it could be like a trigger due to simple factors like simple touch or exposure to the cold also can produce that. Now, this is one of the common complications of the herpes. So, I'm not dealing with the eruptive phase of the herpes today. I'm just talking about the post-herpetic neuralgia which occurs, which can be quite troublesome. At times, the pain may last for years together. Usually, it subsides in 1 or 2 months, but at times it could be years together. And such of the patients, the approach to the treatment would be based upon the Visarpa Lakshanas. Now, from Ayurvedic point of view, though Visarpa is mentioned as the eruptive phase, the features which can occur for the later duration also are mentioned as a part of the clinical history. A Vataja Visarpa would have that pain, Shotas Purana Nistoda, where there could be acute pain, whereas a Pittaja Lakshana, there would be burning sensation. Of course, Charaka also says about the Kapaja complication, which is not generally seen in the clinical practice. Most of the times, what we see in the neuralgias would be either the acute pain or the burning sensation. Itching feeling is comparatively less commonly seen in the clinical practice. My approach to the treatment in such conditions again, depending upon the doshas, like if the patient has the acute pain, my prescription would be Ekangvila. If it is the burning pain, it's the Kamaduga. Smithsagar Rasa is usually given as a Kevala Vatsajanya Vyati. Along with that, either Saraswata or Ashwagandha Rishta is given. Saraswata Rishta in those patients who have more of the acute pain, Ashwagandha Rishta where the patient would have comparatively dull type of the pain is the usual prescription. In very and of course Anutelanasya, another Anutelanasya also is often prescribed. In very severe patients, Dashamula Nirohbasti also could be prescribed when the patients would have the pain for a very long duration, like months together, 6 months, 7 months, and so on. In such conditions, it can produce the Basti can be one of the other prescriptions. Now, that's about one more of the neurological condition. Next set of the neurological condition, again, most of the neurological diseases would have a vague terminology and they include a large number of conditions. And among them, another vague terminology condition is a motor neuron disorder, MND. It could be produced due to a large number of conditions, pathologies. It often, the definition of motor neuron disorder is where the motor nerves, the lower motor segment nerves are affected, and as a result of that, the movements are affected gradually. The particularly corticospinal nerve fibers are those alpha nerve fibers which are affected. They may be of different type of the pathology. Either it could be amyotrophic lateral sclerosis where the spinal ganglion could be affected, or it could be the post-polio syndrome again, where again the spinal ganglion could be affected. Difference between a post-polio and the lateral ALS is the post-polio conditions, the damage is permanent. There is no question of recovery. Whereas in the ALS, it's usually sclerosis which occurs. The nerves are not completely damaged, and there is a scope for recovery. And typically, onset in amyotrophic lateral sclerosis is comparatively sudden, and the disease is progressive. In the post-polio conditions, that poliomyelitis, the onset, once it has occurs as an episode of febrile condition, but later the damage is continuous. In a typical post-polio syndrome, there will be lower motor neuron-like lesions and hence a gross atrophy of the muscles would be seen. Whereas in lateral sclerosis, the patients may have a increased tone. The tone of the muscles may be increased along with atrophy. Now that's very typical clinical sign. A patient who has an atrophy as well as the muscle tone being increased. That's very typical of the amyotrophic lateral sclerosis clinical condition. The usual standard clinical examination in case of the nervous system would be in a lower motor neuron lesion, you would expect the patient to have atrophy as well as atony. The tone of the muscles will be reduced, reflexes will be reduced. Whereas in a typical ALS-induced motor neuron disorder, the jerks will be exaggerated, can be exaggerated, tone is increased, but there could be atrophy of the muscles. So that's one of the important clinical sign which differentiates that motor neuron disorder from that. Now, the motor neuron disorders also could be hereditary spastic conditions, which also are categorized as the motor neuron disease, where the patient may have a family history and the symptoms are comparatively vague as such. Patients of spastic paraparesis would have a difficulty in only certain specific activity, like some of the patients may have a difficulty in certain type of walking or certain type of activity like writing and the spasm during writing. These could be the typical features as such. And comparatively, outcome also is poor. Incidence also is lesser. Another variety of the motor neuron disease is the bulbar palsy, where the patient may have the bulbar paralysis. The patient would find it difficult to swallow, and often the patients require that Rhines tube insertion. And most of the patients would have a progress into other pathologies too, and hence the outcome would be quite poor. So progressive bulbar palsy outcome would be very poor, and quite important to keep the patient alive would be patient has to be fed on the Rhines tube, and that Rhines tube feeding is the lifeline for the patient. Rarely you may get an opportunity where the Rhines tube could be removed. If the Rhines tube is maintained, the patient may otherwise may look normal in such patients as such. So that's which also is a variety of the motor neuron disorder. Now, all these are important when we deal with the patients practically. If the patient has a difficulty in swallowing, like one of the patients whom we have now in the second floor, that 326, she has that progressive bulbar palsy features, where we had inserted a yesterday. Those who come to the clinic these rounds, they may know about it. That's a typical progressive bulbar palsy, along with other neurological deficit in that patient. And in such conditions, Rhines tube would be a must asset. Even a motor neuron disorder could present as a spinal muscular atrophy, where the spinal nerves either could be damaged, injured, and then there could be an atrophy, where the approach to the treatment from iodic point of view would be different. Spinal muscular atrophy, our approach to the treatment would be different, where we will consider the as a Dhatuk Shaidanya Vata Prakopa. Spinobulbar muscular atrophy is comparatively less common in our conditions, but it's often related to the genetics, that the confirmation of the diagnosis would be based upon genetics and comparatively less common. So that's about the spectrum of diseases which are considered as a motor neuron disorder. But instead of going to those varieties based upon the pathological outcome, it's quite important from the practical clinical point of view, the clinical subtypes. The basic clinical subtypes are either limb onset disorders, bulbar onset disorders, or respiratory onset diseases. This would be a better way of dealing with the patients clinically, instead of going into that the genetics and issues. And this also is important from our approach point of view. When I deal with the patients, clinical science or clinical approach, the primary approach would be based upon these features than really going into the genetics and the high level of function, the study of the nerve functions. Of course, the choice of investigation would be the nerve conduction studies or neuromuscular studies would be the choice of investigation. But most of that times, the investigations also would be misleading. They are not very much confirmatory. So, from the clinical point of view, this is enough if we take consider these conditions: limb onset diseases, bulbar onset diseases, where the patient would have difficulty in swallowing, limb onset diseases, where they will be starting with the muscles of the periphery. There could be a weakness of the legs, arms, fatigue, and so on. Or respiratory onset diseases, where the patient may have the shortness of breath or oxygen concentration could be lesser. From the clinical point of view, limb onset diseases are more common, and that's where we can give better results. Bulbar onset diseases comparatively less common, and outcome is poor. Respiratory onset diseases outcome is extremely poor, and most of the times the result is fatal. So this is quite important from the clinical point of view. The other standard clinical signs in case of these limb onset type would be progressively weaker limbs with the progressive atrophy. You might have seen many of the patients who are seen in the clinical practice that they are even admitted in the hospital also. It can be presented by the pain in the joints also. Often many of the patients may complain of only the joints, pain in the joints as the clinical presentation. It may be even a stiffness in the joint, and the patient may have difficulty in certain type of movements, extreme ranges of movements like rotation, or at times it may be often presented as a frozen shoulder-like conditions too. Inability to control the saliva and the drooling drops, right? That's what you see in many of the patients. At times it could be presented as a yawning and then sudden catch that patient may have pain in the. This also could be the initial most clinical symptoms of a motor neuron disease. So clinically, these are all important. You might have seen a few patients who have that history of yawning and then sudden catch as such. And such patients often may have the later progress into a established motor neuron disorder as such. Speech muscles being affected. So many of the patients may feel that they are not able to speak properly, or they have a slurred speech, and they feel some difficulty in the throat and mouth during the speech as such. So this could be also the clinical presentation of the motor neuron disorder. And there could be even grosser global symptoms like memory loss or other brain functions like integrative functions, thought functions could be affected. So many times some of the patients of motor neuron disorder may be confused with the psychiatric onset too. So clinically, it's quite important to make the diagnosis of motor neuron disease after classic, careful presentation. Now, from the management point of view, particularly ALS and PLS are limb onset conditions. Particularly limb onset, our major interest would be of limb onset conditions. In that condition, my prescription would be Chandraprabha Ekangura Ashwagandharishta Matra Basti or Niru Basti, and the outcome would be somewhat better. As I told you earlier, in case of bulbar onset or respiratory onset, outcome would be poorer, and the typical description of the this would be in the context of the Vata Prakopa Lakshanas, where the outcome would be somewhat better. Whereas Avaranajanya conditions, Sushruta has described about these Avaranajanya conditions, where there will be the Shleshmapiktabhyam Pranam Chaudanam Avratam, where the patient would have typical bulbar onset conditions. Again, the treatment will be same, prescription would be same, but the outcome is poor. Nirohabasti is prescribed. So those who have that bulbar onset, I would consider as the Udana Prana, Prana and Udana Anyonya Avarana, or the any other variety of the Prana Avarana could be considered. And as Sushruta has said, Vishesha Jikam Prana Udana Samshidam Balam. Even it can be fatal when there is a Udana Avarta Prana as such. And particularly, of course, Sushruta has given that description when they are long duration. Aparijnataha parisumatsaraha, because the diagnosis is difficult, at times they may be left undiagnosed for long duration like 1 year or so on, and then it becomes asadhyaha dulpokramaha, and that's exactly what happens in the clinical practice. So that's about the motor neuron disorder. And the final word when Becharaka is Yasya Dhatukshaya Vayu Samyam Karmachanashayat Prakshinam Chabalam Yasyana Asau Shakya Chikitsu. When there is a typical Dhatukshaya Vyakti, it cannot be treated and the outcome is a fatal asset. So that's about the issue of motor neuron disease. So we will stop at this moment today. Next we will discuss about stroke and then convulsive disorders, and we'll try to conclude about the neurological disorders in the next session. So with that, thank you. If there are any questions, I'll try to answer the questions. In case of acute otitis media, the patient has, yeah, that's true. Otitis media also can have the patient symptom of Bell's palsy, and there, of course, the treatment will be the same. If the patient has severe acute otitis, a short course of antibiotic may be necessary occasionally, but otherwise, a Bell's palsy and otitis, the treatment will be the same. There is no question of other differences. That's it. And of course, pain management also could be one of the issues in case of otitis. Right. Then relationship between thyroiditis and Bell's palsy. Of course, there is no such established relationship, but any systemic inflammation could be one of the triggering factors for the Bell's palsy. There is no established relationship between thyroiditis and Bell's palsy as such. That's about one more question. Right. I think there are no more questions, I think. So, right. So, we'll wind up today. Thank you.
Thank you, sir.